patients, it is associated with higher overall survival and progression-free survival for metastatictomy in the pulmonary, liver, and pancreas mets. For bone metastasis, we should give single dose of image-guided radiotherapy 24 gyrate and external beam radiotherapy. For brain metastasis, we should give stereotactic radiosurgery and whole brain radiotherapy. Overall survival benefit is more with this stereotactic radiosurgery with the whole brain radiotherapy. Embolization prior to the resection of the hypovascular or bone or spinal mats, it reduces the blood loss, and palliative in case of the painful bone metastasis. Favorable factor for the metastasiectomy is the solitary metastatic lesion, age less than 60 years, pulmonary metastasis less than 4 centimeter, and disease-free interval of more than 1 year, and metachronous lesions. Now, these are the EAU 2025 recommendations for the local treatment and of the metastasis. That is, we should not offer tyrosine kinase inhibitor therapy to the metastatic renal RCC patient after the metastasiectomy and no evidence of the residual disease. Systemic therapy. Systemic therapy includes immunotherapy, targeted therapy, and chemotherapy. Immunotherapy includes treatment with interferon alpha, interleukin 2, and immune checkpoint inhibitors. Basis for the immunotherapy is there is the spontaneous remission has been documented after the immunotherapy. There is increased risk in case of the immunodeficient patient, so we should give immunotherapy. And tumor in this is the mechanism of the immunotherapy. When cancer cell dies, it releases the cancer cell antigen. That is identified the antigen presenting cells, and priming of the T cells and APCs occurs. That leads to the trafficking of the T cells to the tumors, and the infiltration of the T cells in the tumors. So with the various immunotherapy acts on these different steps. Interferons, it is the protein with the immunomodulatory property, that is interferon alpha. Recombinant interferon is used nowadays, but it was previously used commonly agent of the choice, but initial treatment for metastatic RCC. But after the advent of the VEGF pathway antagonist, it is no longer used nowadays. Interleukin 2, response rate is increased by 15 to 20%, but interleukin 2 is associated with the severe side effects. So these are also not used nowadays. Current role of the cytokine therapy is single agent interferon, once the standard of the main institution, is no longer used in the treatment of the renal cell RCC. High dose interleukin 2 remains a reasonable option in most careful selected patients with the metastatic clear cell RCC. Checkpoint inhibitors. Immune checkpoint inhibitors, these are the three types. One is PD-1 inhibitors, another is PD-L1 inhibitor, and the CTLF-1 inhibitors. PD-1, antibody against the PD-1 is the pembrolizumab, nivolumab. Antibody against the PD-L1 is atezolizumab, durvalumab, and avelumab. And antibody against the CTLF-4 are the ipilimumab. Now, doses, pembrolizumab used in the 20 milligram IV thrice weekly. Duration is until the disease progression on the unacceptable toxicities. Nivolumab is used 250 milligram IV twice weekly, or 480 milligram 4 times weekly until the disease progression or the unacceptable toxicities. Nivolumab plus ipilimumab combination is used in the immune checkpoint inhibitors. 3 milligram per kg IV nivolumab given immediately, followed by ipilimumab 1 milligram per kg IV on the same day every 3 weeks. Up to 4 doses are given or until the unacceptable toxicity develops. Now these are the different trials that shows the recommendation of the immune checkpoint inhibitors over these sunitinib. Keynote trial includes the pembrolizumab plus exitinib, and second arm is the sunitinib. There is progression-free survival is increased in the pembrolizumab and exitinib pembrolizumab and exitinib, but sunitinib there is decreased progression-free survival. Checkmate 214 trial includes the nivolumab plus ipilimumab, and second arm is the sunitinib. Progression-free survival is more in the nivolumab plus ipilimumab, and the overall survival is more in the nivolumab plus ipilimumab. And Checkmate 9ER and other clear trial also shows that the immune checkpoint inhibitors are superior to the tyrosine kinase inhibitors. Adverse effect of the immune checkpoint inhibitors are severe autoimmunity, hypophysitis, vitiligo, and diarrhea. Immune checkpoint inhibitors are not easily available in the India. Common immune checkpoint inhibitors are nivolumab, pembrolizumab, atezolizumab, durvalumab, and ipilimumab. Pembrolizumab costs 2.5 to 3 lakhs per month, and nivolumab costs the 1.8 to 2.5 lakh per month. Estimated total treatment cost is 15 to 40 lakh, depending on the duration of dosing. Pembrolizumab is manufactured by the Merck. One vial cost is 97,000. Oppido is manufactured by the Bristol Myers, and one vial cost is 40,000. Barriers to the access in India for the immune checkpoint inhibitors are high out-of-pocket costs for the most of the patient, limited availability in the public hospitals, cold chain logistic and infrastructure is needed, lack of awareness in the smaller centers, and delayed or interrupted treatment due to the affordability. Patient impact: only major metro hospitals regularly stocks ICIs, high financial burden for the families, inconsistent on delayed treatment, limited access to in the tier 2 and tier 3 cities. Government and policy changes: ICIs are not included in the Ayushman Bharat Yojana. No government price regulations on immune checkpoint inhibitors. Biosimilar approval is still pending in the many cases, and the import dependency increases the cost variability. Another targeted therapy is the targeted molecular agent in the clear cell carcinoma are the antagonist of the vascular endothelial growth factor and its receptors, inhibitors of the mammalian target of rapamycin, and tyrosine kinase inhibitors. Now, in clear cell carcinoma, VHL mutation causes the accumulation of the hypoxia-inducible factors that causes the upregulation of the pro-angiogenic growth factors like VGF, PDF, TGF-alpha, and GLUT1 erythropoietin. This is the VHL pathway. Everolimus and sirolimus acts on the mTOR, and bevacizumab acts on the VGF, and pazopanib, axitinib, sunitinib, sorafenib acts on the VGF receptors and PDGF receptors. Now, antagonists of the vascular endothelial growth factors are, first is bevacizumab. It is humanized monoclonal antibody, and the dosage is 10 mg per kg, administered every 2 weekly IV. Significantly longer progression-free survival rate of 4.8% versus 2.5 months in place compared to placebo. Bevacizumab is not widely used nowadays as a single agent initial therapy. In patients who have failed standard first-line VEGRF antagonist, used either alone or in combination with the agent with the interferon alpha. Sorafenib, it is the oral receptor tyrosine kinase inhibitors with activity against the VEGFR2, PDGFR beta, and RF1. Dosage is 400 mg BD. Side effects are hypertension, fatigue, rash, and hand-foot syndrome, and diarrhea. There are two trials. One target study shows the compares the sorafenib versus the placebo. Overall survival was 7.8 months versus 4.3 months in the placebo. Now, sorafenib is infrequently used as the first-line agent because of the advent of the targeted therapy in immune checkpoint inhibitors. Sunitinib is the oral VEGFR tyrosine kinase inhibitor. It is a potent inhibitor of the VEGFR2, PDGFR beta, and c-KIT and FMs like tyrosine kinase inhibitors. So it simultaneously targets the VEGF and PDGF pathway. So these are responsible neoangiogenesis by this agent, likely to act synergistically in inhibiting the tumor angiogenesis. Dosage is 50 mg per day, 4 weeks on and 2 weeks off, schedule until the radiological confirmation of the clearance of the progression. Effect trial compare the two doses, 50 mg per day, 4 week on and off, and 37 mg per day continuously. Effect trial suggests that 50 mg per day, 4 week on and off is the preferred schedule. Side effects are the diarrhea, rash, hand-foot syndrome, and fatigue and asthenia. Bone marrow suppression and hypothyroidism is notable side effect. Sunitinib was widely used as the first-line treatment of metastatic RCC until the recent trial, that is Checkmate 214 trial, has demonstrated the superiority of the PD-1 or PD-L1 checkpoint inhibitors based on the combination of the sunitinib in the intermediate and poor risk group. But in the good risk group, sunitinib is still preferred. Pazopanib is the potent inhibitor of the VEGF receptors, but it remains its activity against the PDGFR. Compared to pazopanib and sunitinib, it doesn't have the side effect profile like sunitinib and sorafenib. This is the trial, COMPASS trial. That is a non-inferiority trial between the pazopanib and sunitinib. But overall survival was similar between pazopanib and sunitinib, but side effect profile is lower in case of the pazopanib. Only mild hepatotoxicity occurs in the pazopanib. PISCES trial compares the pazopanib with the sunitinib. Pazopanib was preferred by 70% compared to the sunitinib 22%. Based on these trials, pazopanib is reasonable first-line option. Exitinib is the highly selective second-generation oral tyrosine kinase inhibitor of EGFR. Dosage is 5 mg BD, increased up to 7 mg BD. Exitinib is approved by FDA for the second-line setting in the patient with the advanced RCC. Axis trial compares exitinib versus sorafenib. Progression-free survival was 6.7% versus 4.5, 6.7 months versus 4.7 months. That is statistically significant. Exitinib resulted in the significant longer progression-free survival compared with the sorafenib. Exitinib is the treatment option in second-line treatment options in case of the patient is not responding to the other tyrosine kinase inhibitors, or the immune checkpoint inhibitors are not available. Newer agent of the targeted therapy is the cabozantinib. It inhibits the VEGFR, MET, and XL genes. Meteor trial compares cabozantinib with the everolimus in patient prior therapy, that is VEGFR and VEGFR inhibitors. Overall survival and progression-free survival was better with the cabozantinib. So it is the recommended for the options in patients who have received the prior antagonist inhibitors. Dose is 60 mg oral OD until the patient experiences clinical benefits or the toxicity levels. Other targeted therapies, the inhibitors of the mammalian target of rapamycin, that includes sirolimus, temsirolimus, and everolimus. Temsirolimus given 50 mg weekly IV. It improves the overall survival and progression-free survival. It is first line for the poor risk patient. Side effects are the mucositis, fatigue, rash, hyperglycemia, and hypophosphatemia. Everolimus is the oral mTOR inhibitor. Dose is the 10 mg OD. It is the regional option in the combination with the lenvatinib. Now, these are the EAU 2025 recommendation of the systemic therapy. We should offer the nivolumab plus ipilimumab, pembrolizumab plus exitinib, and lenvatinib plus pembrolizumab or nivolumab and cabozantinib in patient with the IMDC intermediate or poor risk patients. We should offer sunitinib or pazopanib in patient with any IMDC risk who cannot receive or tolerate immune checkpoint inhibitors. We should offer cabozantinib to the patient with IMDC intermediate and poor risk clear cell metastatic renal carcinoma who cannot receive or tolerate immune checkpoint inhibitors. Now, we should offer nivolumab or cabozantinib for those patients who received first-line VEGF targeted therapy. Do not re-challenge patients who stopped immune checkpoint inhibitors because of the toxicity without expert guidance and support from the multidisciplinary team. Now, this is the updated EAU guidelines recommendation for the first-line treatment of the clear cell metastatic RCC. In case of IMDC favorable risk groups, standard of care is the nivolumab, cabozantinib, or pembrolizumab, exitinib, pembrolizumab, lenvatinib, nivolumab or ipilimumab, and sunitinib or pazopanib for favorable risk group. In IMDC intermediate or poor risk group, we should use nivolumab plus any of these, nivolumab plus cabozantinib, pembrolizumab plus exitinib, pembrolizumab plus lenvatinib, or nivolumab plus ipilimumab. Alternative to IMDC intermediate and poor risk group patients are if immune checkpoint inhibitors not available and severe toxicity is there, we should use cabozantinib, sunitinib, and pazopanib. EAU guidelines recommendation for the second-line therapy. If patient has taken prior tyrosine kinase inhibitors or immuno-oncological immune checkpoint inhibitors, standard of care for second line is cabozantinib or any VEGFR target therapy that has not been used previously in the combination with the immune checkpoint inhibitors. If patient has used only prior tyrosine kinase inhibitor but not the immune checkpoint inhibitors, we should give nivolumab plus cabozantinib to this patient, or alternative is the exitinib. And several prior lines of immune checkpoint inhibitors or tyrosine kinase inhibitors are used, then we should give belzutifan, that is HIF2 alpha inhibitors. These are the NCCL guidelines of the metastatic RCC. So this is the flow chart of the treatment of management of the metastatic RCC patient. If patient present with the suspected RCC and if it is CT scan or MRI suggests locally advanced disease, lymph nodes are involved, clinical symptoms suggest cough, bone pain, or weight loss, or fever, or lymphadenopathy, then we should do metastatic workup. If CXR shows the nodule in the chest, we should go for CT thorax. If patient present with the symptomatic bone pain, we should go for bone meds, in which RCC metastases are the osteolytic lesion, and these are radiolucent. We should go for PET scan and brain MRI if it is clinically indicated and patient present with the symptoms of the brain metastasis. We should do blood investigation for the risk stratification, that is calcium, AFP, LFT, CBC, and after that, if it shows the metastasis, then we should go for tissue diagnosis, that is by renal biopsy. And by investigation, we should do risk stratification according to IMDC and MSKCC. If primary tumor is resectable and good performance status is there, we should go for cytoreductive nephrectomy. And if it shows if metastasis is limited, we should consider the metastasiectomy followed by systemic therapy. If IMDC risk stratification patient shows poor risk stratification or high risk, then we should start systemic therapy or palliative local therapy for the metastatic tumor, that is embolization or radiation therapy. For systemic therapy, immune checkpoint inhibitors in combination, not alone, with the two immune checkpoint inhibitors are used. Preferred therapy is the nivolumab or plus ipilimumab. We should monitor the response according to RECIST criteria and we should adjust the therapy and sequence as they needed. And we can also use the targeted therapy, that is VEGF and TKI-mTOR inhibitors. Thank you.
Thank you, sir. To ask you, sir, have you also shown what specific therapies as a first line and second line? They're also given in say non-clear cell.
Sir, for non-clear cells, sir.
Have you shown it? So basically, your seminar was on metastasis for RCC, metastatic RCC.
Yes.
So when you well know that 30% of metastases are non-clear cell, then don't you think that this is important to discuss in the seminar? Yes, maybe sir. Your computer clear cell is a big segment. And that is the whole problem that we're having, is that we're not focusing ourselves on non-clear cell. I don't think that you should have, you should have at least compared it. What you should have done in Chennai is that you should have made a slide. And okay, so basically it is just dividing based on histology and stratification, whether it is clear cell or non-clear cell. Right. These days, as a matter of fact, a number of papers coming in which for some reason we are getting more of non-clear cell tumors. The classical RCCs, maybe it's on account of the molecular histology changes that we are seeing, or maybe of better reporting. So that's why non-clear cell has, slowly eating into it. Valley of the 80% of RCCs, they are clear cells, but now this been shift. 65% are clear cells. So you did not even touch upon non-clear cell, which is wrong. Maybe you could have made a table that, okay, if there is metastasis, for clear cell, we have to do this, for non-clear cell. So this is my critique of your seminar. That's because I was waiting for you to discuss about that. Because what happens is that if the patient clinically comes to us, then we all aggressively treat a clear cell. But as soon as non-clear cell variety comes in, what happens is that we are cutting a sorry picture and then sending the patient to oncology. We should be also discussing non-clear cell. Yeah.
So for non-clear cell, we usually use the mTOR inhibitors.
So see, everything is there in text, but how it should have been discussed in the seminar. Because your seminar is just not limited to maybe clear cell RCC. Maybe your moderator would like to make a few comments about this. And anybody else from the want to chip in, any comment about?
Sorry, sir. This time we didn't.
No, so, okay, just, because the seminar did not encompass just clear cell. Yeah.
Big mistake, because we have discussed only the clear cell metastatic. Next time we will.
Anything you'd like to add about the, how to go ahead now with, metastatic? Still, the majority of patients, they come with locally advanced and metastatic. Would you like to shed some light upon how we inside our department, how we should proceed in these cases? Because anything you want to add to this?
Please, sir. Please, please comment.
So I think we're having the seminar without Shivam, sir. I am not sure whether he is joined us from England, because it must be around maybe 5 o'clock, 4 o'clock in England. So we wish him a great time over there. And so today's seminar was basically about the treatment of metastatic RCC. And when I was going through the slides and I saw that Dr. Nehal he hadn't touched upon non-clear cell. So I think that is important. Maybe another seminar we can keep on metastatic non-clear cell. This is because, as a matter of fact, with better TKI and with better immunotherapy, non-clear cells also the response rates and the survival is increasing rapidly. And uh, I think that one thing that you should have done is that maybe at the end you could have just made a slide to the point of repetition about it becomes easier. What is the first line? What is the second line when the patient has adverse events? What do we do and what do we not do? Uh, that is the thing. Maybe NCCN guidelines, as we discussed. I don't know which guidelines you discussed. You discussed what the AUA guidelines. Yeah, so the AUA guidelines and the NCCN guidelines, they are roughly the same. Personally, I feel that cabozantinib is coming in a big way inside both the groups, maybe clear cell as well as non-clear cell, and pembrolizumab. Even though a few years back it used to be the primary first drug, but however, cabozantinib is showing more promise as compared to pembrolizumab. Sorry, is someone has to be muted? Please mute your video, please. So I think that cabozantinib is coming in a big way for both all varieties of RCC. Combination of cabozantinib with maybe pembrolizumab and also nivolumab is also showing promise inside non-clear cell. And with this, we are going to wind up the seminar. If there is any comment from the faculty, Dr. Punia, Dr. Sau, Dr. Suminder, any comments you want to make about it? Any resident wants to ask any question? I think that in one seminar, we should also discuss what the present status of getting a PT scan is, because PET scans routinely we are not doing inside our metastatic cases. But I believe that in metastasis case of RCC, it's come in a big way. In all cases, if we think that it's a big primary tumor or a feature suggests, biochemical features or clinical features suggest that we should get a PET scan, I am a firm believer now that PET scan should be done routinely inside all cases of RCC. It doesn't add to the cost of the treatment, and I think that it adds more value to the management. So we need our own data about whether routinely we should add a PET scan. I know many centers, especially in Delhi and Bombay, which are doing PET scan routinely, and I think that PET scan uh, we should be maybe you could have added that what is the present role of PET scan inside the evaluation of metastatic RCC, because your topic was that. So maybe you can come up with answers of that. In our Indian scenario, I mean, can we do a PET scan more aggressively and more frequently inside metastatic RCC? Yes. And it's a commonly answered, well, it's a commonly given question inside your theory. You should know, you always get a renal lump inside practical. So it's important from your theory point of view. It's also important from your clinical examination point of view, from your practical point of view. And you don't have to remember everything, but however, the main important trials, as you said, like the STAR trial and with the PISIS trial and all, and inside both, if you just remember one or two groundbreaking trials, right? And presently, the workhorse is against sunitinib, and we still give sunitinib about the 50 milligrams that you said. No, people now are starting with lesser dose like 25 milligrams, 37.5 in order to reduce the side effects. And one thing that you just should have said is that if there are side effects, then that means that the drug is working. And maybe how to deal with hand-foot syndrome. That was also a pertinent part of your seminar, maybe which you and your moderator should have covered, right? The management and what the etiopathogens of hand-foot syndrome and what it means clinically. The development of hypothyroidism and all is important because newly onset hypothyroidism is a good prognostic marker. Then again, the on and off, there have been constantly changes inside the on and off treatment, 4 weeks on, 2 weeks off. Now people are giving 3 weeks on and 3 weeks off. And now the latest seems to be 2 weeks on and 2 weeks off. It's easier for a patient to have a monthly cycle, especially in our setting also when patients only get medicines for 1 month. So I give 2 weeks on and 2 weeks off. So it's not wrong. And maybe you could have touched upon that aspect. And with this, we are winding up the seminar in time. And thank you very much. And maybe I'll not be ending the seminars from now on. I think that it is the prerogative of the moderators. Yes, you want to say something, please. You have MCQs. So, right. Okay. He has a few MCQs. So he'll be discussing the MCQs and then maybe we can just wind off and call it a day. And thank you so much for joining. So I'll not be coming back now. Thank you so much. Now,
In the Memorial Sloan Kettering Cancer Center, prognostic scheme for the patient with metastatic RCC undergoing therapy with cytokine or chemotherapy, which of the following is not a predictor of poor outcome? Karnofsky's performance status greater than 80%, elevated lactate dehydrogenase, elevated calcium, decreased hemoglobin, an interval from diagnosis to systemic therapy initiation of more less than 1 year.
I don't know, maybe it's inevitable from diagnosis. I don't know.
So it's because
Tell the answer.
yes, sir. Karnofsky performance status greater than 80%. A Karnofsky performance score below 80% was determined to be an adverse prognostic factor. A 50-year-old old man with a 12 centimeter left renal mass identified on a CT scan to evaluate abdominal pain is referred for further management. He is otherwise healthy except for the mild fatigue that has developed over the past 3 months. Laboratory evaluation reveals a hemoglobin of 9.8 milligram per deciliter and an elevated corrected calcium 10.8 milligram per deciliter, but an otherwise normal chemistry panel or complete blood count. CT scan of the chest reveals multiple pulmonary nodules consistent with metastatic disease. A biopsy of renal mass reveals clear cell RCC, Furman grade 3. Which of the following true with regard of surgical management of this patient? A cytoreductive nephrectomy should be performed since this patient appears to be otherwise healthy with a good performance status. Systemic therapy should be offered to this patient since he is unlikely to benefit from cytoreductive nephrectomy. Systemic therapy should be commenced with cytoreductive nephrectomy after 6 cycles of sunitinib. The patient has a high-risk disease, should commence therapy with everolimus.
What is it?
So it is B, sir.
Therapy should be on patients unlikely to benefit.
Because of intermediate and high-risk groups of patient belongs to.
What is your source?
Sir, it is Campbell review.
This is a Campbell's review. This is a cut and paste of Campbell's review, is it?
Yes, sir.
Cut and paste.
No, sir. Campbell review questions are taken from.
Campbell's review saying cut and paste.
Yes, sir. Yes, sir.
Okay, you didn't make your own questions.
No, sir.
Okay. What the answer is?
Sir, answer is systemic therapy. As this patient belongs to, sir, IMDC intermediate and poor risk group, sir. So in intermediate and poor risk groups, systemic therapy is preferred over the cytoreductive nephrectomy. A 58-year-old old woman had a nephrectomy 6 years previously for a grade 2 clear cell carcinoma. She was incidentally found to have 3 left-sided pulmonary nodules, 2 less than 1 centimeter, other 2.5 centimeter. A physical examination is normal and as are all the blood chemistries. Computed tomography of the brain, lung, abdomen, and pelvis shows 3 pulmonary nodules with no associated hilar or mediastinal lymphadenopathy, and a bone scan is normal. Which of the following is the most appropriate next step in her management? Therapy with high-dose interleukin-2, biopsy of the pulmonary nodules, mediastinoscopy followed by resection of the pulmonary nodules, observation and interferon A therapy.
There's a followed by resection of pulmonary nodules.
So it is
This is too much observation. I emphasize this one significant size. That's why I think that 6 years from grade 2, what is it?
so it is C, sir.
C, medianisonopy followed by resection.
So, sir, disease is that is only pulmonary metastasis is involved, not hilar lymph nodes are involved, that is resectable, and pulmonary nodule size is less than 4 centimeters. So, the sirolimus analog, temsirolimus and everolimus act primarily on the which of the following pathways? Vascular endothelial growth factors, platelet-derived growth factors, RF1, mammalian target of rapamycin, CMAT. Sir, it is D, sir, mammalian target of rapamycin.
That is the only thing.
Yes, sir.
Any questions? So, take it to.
Fifth question. A newly diagnosed patient with metastatic clear cell RCC is referred for discussion of systemic therapy. You determine that he has the intermediate risk disease based on the standard prognostic criteria and that systemic therapy should be commenced. Which of the following decisions would be supported by the data from randomized phase 3 studies? Sunitinib is the most appropriate choice of initial treatment of this patient. Initiate therapy with a combination of nivolumab and ipilimumab, since it is associated with better response rate and overall survival compared with sunitinib. Initiate therapy with a combination of pazopanib and nivolumab. Initiate therapy with a combination of lenvatinib and everolimus.
I think the answer could be.
Yes, sir.
Answer is B.
Please. Which of the following agents has been shown to prolong progression-free survival in patients with metastatic clear cell RCC who have progressed on first-line therapy with VEGFR receptor antagonist? Axitinib, bevacizumab plus interferon alpha, high-dose interleukin-2, bevacizumab.
That should be B. Bevacizumab definitely been shown. I think so. What is the answer?
Sir, it is axitinib, sir.
Axitinib.
Yes, sir. Second-line therapy. Actually, sir, bevacizumab is sir VEGF antagonist, and bevacizumab is no longer used as a first-line therapy nowadays, sir. And second-line therapy, axitinib is preferred in case of
Progress on first line. Okay.
yes, sir, on progress of first-line. Randomized trial in the patients with previously untreated metastatic clear cell RCC have demonstrated that the combination of pembrolizumab and axitinib is associated with better overall survival compared to sunitinib. The combination of avelumab and in combination with axitinib is associated with better progression-free survival compared to sunitinib. Cabozantinib is associated with a better response rate and progression-free survival compared to sunitinib. All of the above, none of the above.
So then all of the above.
Yes.
Cabozantinib versus the second-line therapy. Combination of cabozantinib and pembrolizumab also is being used. Yeah.
Sir, all of the above.
Okay.
Which of the following agents has been shown in randomized phase 3 trial to prolong survival in poor risk metastatic RCC patients? Interleukin-2, sunitinib, sorafenib, temsirolimus, and interferon alpha. Sir, answer is D, sir, temsirolimus. All these drugs are beneficial. Other drugs are beneficial in the good risk group, and temsirolimus is beneficial in these intermediate and poor risk.
Interleukins also continue to be used in same metastatic RCC. They have any present roles in interleukins. So in go back to the question, multiple questions may interleukins are coming and interferons. And interferons presently they don't seem to have any role. So
no,
presently, is there any role that you studied because you have done this exam? The role here?
No, sir.
Sure.
Sir.
Thank you very much. Thank you, sir.
And thank you so much. But the next time we will prepare for the other than the clear cell carcinoma. Thank you so much. Thank you.